Hello, everyone. Welcome to the FASD and Sleep webinar. I'm very excited to be welcoming our guest speakers today. And before we start with their presentation, I want to acknowledge the Indigenous peoples of all the lands that we are on today. So it's important to do this land acknowledgement, even though we're on a virtual platform, and take a moment to acknowledge the importance of the lands and which we call home. And we do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their culture. So from coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home. And please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we are and can each in our own way try to move forward in a spirit of reconciliation and collaboration. In my case, I'm in Gatineau, near Ottawa, land of the Algonquin Anishinaabe people. So I'm going to be presenting our speakers today, Dr. Penny Corkum, Dr. Anna Hanlon-Dearman, and Dr. Shelley Weiss, who are joining us today. So Dr. Weiss is a pediatric neurologist at Sick Kids, Toronto, Ontario, and a professor at the Faculty of Medicine at the University of Toronto. And Dr. Weiss has a leadership role in sleep disorder internationally as the elected representative for North America on the governing council of the World Sleep Society. Nationally, Dr. Weiss has been a past president of the Canadian Sleep Society and currently is a vice chair of the Royal College of Physicians and Surgeons of Canada. She has a diploma in sleep disorder medicine, and her research is focused on medical and surgical treatment of drug refractory epilepsy in children and interventions to improve sleep in children who are typically developing or those who have neurodevelopmental disabilities. Dr. Anna Hanlon-Dearman is a developmental pediatrician at the Manitoba FASD Center at the Child Development Clinic with the Child Health Program in Winnipeg, Manitoba. She is a professor of pediatrics and child health with the University of Manitoba and holds a cross appointment with the Department of Community Health Sciences. She was awarded the Manitoba FASD Research Scientist Award from Healthy Child Manitoba Office with the University of Manitoba Community Health Sciences and chairs the research group at the Manitoba FASD Center. Dr. Hanlon-Dearman has been working collaboratively with a number of research teams to understand population health issues of individuals with FASD and to better integrate care for affected individuals and their families. Her clinical and research interests include neurodevelopmental patterns of children with FASD, as well as children with a variety of neurodevelopmental disabilities. And finally, Dr. Corkum is a registered psychologist and a professor in the Department of Psychology and Neuroscience and Psychiatry at Dalhousie University. She conducts clinical research in the areas of sleep and school mental health with a focus on children with neurodevelopmental disorder. She has a particular interest in e-health, which is using the internet to deliver interventions. One of her research areas is aimed at the intervention of pediatric sleep problems with the primary goal of to reduce the impact, negative impact of sleep problems on the child, that is attention, learning, behavior, social emotional development, and the functioning of the family. So without further ado, we're going to turn over to the speakers.
Yeah, welcome to tonight's webinar. It's a real pleasure to be able to speak to this audience, and thank you to Health Nexus colleagues for inviting Penny, Anna, and I. We're very close colleagues. We do research together. We've been working together for a long time, and unfortunately, we're not together tonight in person and with you in person, but I hope that you will all enjoy this virtual seminar. And feel free, as Pascal said, to put your questions in the question and answer box, and we'll be happy to answer them. So we're going to talk for the next hour about FASD and sleep, and then we're going to leave 15 minutes time for questions. So just disclosure information. And sorry, I didn't say I'm Shelley Weiss. So I'm from the University of Toronto, as you heard, and I'm a pediatric neurologist. So I'm going to give some general information about insomnia. I don't have any disclosures relevant to the presentation. Then Dr. Hanlon-Dearman is going to talk about insomnia in children with FASD, has no disclosures, and Dr. Penny Corkum will talk about better nights, better days, an intervention for children with FASD and insomnia, and her disclosures are listed as commercialization potential for BMBD, and research funding from CIHR, Kids Brain Health Network, the IWK Health Center, and Dalhousie University. So as I've just said, the first part is general information. The second part, actually, Penny Corkum is going to go second and talk about better nights, better days. And then Anna Hanlon-Dearman will talk about insomnia, and then we'll answer questions in children with FASD, and then we'll answer questions. So just because the audience ranges from service providers to parents, and obviously not everybody has the same information, I want to start with some basic facts, just so that you understand a little bit about sleep and what insomnia means. So I'm going to talk about what is insomnia, how common is it, what causes insomnia in children, and what are the consequences when children have insomnia and don't sleep well. So we'll first start with understanding sleep. This is going to be extremely basic, understanding sleep in one slide. And, people spend their whole life researching the understanding of sleep. So this is a very quick review. So what's really important to understand about sleep is that we don't just sleep through the night and not wake up. So all children, adults, no matter what your age, we wake up several times at night and then we go back to sleep. So I'm just going to show you a quick graph of what sleep looks like. So here on the y-axis is the different stages of sleep. So 1, 2, 3, 4 are what we think of as slow wave or restorative sleep. REM is dreaming sleep. And then obviously you have to be awake at the beginning of the night. And then along the x-axis is the hours through the night. So this would be bedtime, 1 hour, 2 hours, 3 hours, etc. So what I want you to see from this graph is that obviously you have to start awake before you fall asleep. And then you have cycles of sleep that change. So first you'll have very deep, this is the deepest slow wave sleep at the beginning of the night. And then you might wake up. And then you go back into some deep sleep. And then you might not wake up. You might just have some dreaming sleep. Then you might go back into kind of a lighter stage of sleep, have dreaming sleep, a little deeper sleep, dreaming sleep. You might even wake up here and then go back down into sleep. So people wake up through the night. So when we talk about, poor sleep or insomnia or not sleeping through the night, we're actually not talking about really sleeping through the night, even though that's what we describe. What we're talking about is that when you have these little arousals, when you wake up between one state and another, you don't disrupt your family or require your parents to, go help you if you're a child, that you learn how to put yourself back to sleep each time that you wake up at night. And this is really important in understanding insomnia, that we don't actually sleep through the night. We do wake up at night, but we are able to go back to sleep after a very brief arousal. So the other important thing about sleep is thinking about how much sleep children need. If you haven't seen, this is from the National Sleep Foundation, and the website is here. It's available to the public. This is just a graph of how much sleep people need. The blue is sort of the recommended, the dark blue. So obviously it changes for each age. So a toddler may be recommended to have 11 to 14 out of 24 hours of sleep, preschooler 10 to 13, school age 9 to 11, and a teenager between 8 to 10 hours. And then the light blue is what might be acceptable. So some, but very few teenagers would be getting enough sleep with 7 hours. Others would be needing 11 hours, but these would be sort of the outliers. Most teenagers would need 8 to 10 hours of sleep. This is also really important because sometimes there's a mismatch between children and parents, where a child may only need 10 hours of sleep, but the parent would prefer they sleep 12 hours. And so they may say, their child's not sleeping well, but really they're getting enough sleep for their age. So the next is, what is insomnia? So insomnia is really simple. It's people, I'm not saying children, because lots of adults have insomnia too. People who resist bedtime, so they don't want to go to sleep. They lie down, but they have trouble falling asleep. They wake up a lot at night, or they wake too early in the morning. And obviously, some people have different combinations of this. It might not just be one or the other. People can have trouble falling asleep and night wakings and wake up too early in the morning. But any of these 4 problems is called insomnia. The other thing about insomnia is that it's usually only a problem for parents if their children have insomnia, or for adults if they have insomnia, if it's frequent. So everybody will have, the odd sleepless night where you don't sleep well. We all have that. But what happens with insomnia is that it happens frequently, lasts more than a couple of months. The other important thing about insomnia is that a child may have poor sleep, but they also have to have the opportunity for sleep. So if the child's living in a hectic home and doesn't have enough opportunity to have good sleep, then that's not insomnia. That's, a problem with the environment. And obviously, if you have insomnia, it's not explained by another problem. So you don't have asthma keeping you up, or a child having eczema and itchy skin that's keeping them up. They just are unable to sleep through the night. So what happens with children who have different neurodevelopmental disorders, including FASD? How do they end up having insomnia? What are some of the pathways that are relevant? So, there can be just symptoms of whatever disorder a child has. So, for example, if a child is very rigid and they have trouble following routines and falling asleep, or they're very busy and they can't, let's say they have inattention, they can't turn their mind off, that could cause some trouble with sleep. Environmental factors, so a child who maybe is in a very warm room and they need a cooler room to sleep, or a child with autism who likes light blankets and has heavy blankets. Psychiatric problems, so children with anxiety or depression will have trouble sleeping. Developmental factors, so a child who doesn't understand why they have to go to sleep, even though they're at an age where they're going to school, but they don't understand that they have to wake up in the morning. That can cause problems. And of course, there's other sleep disorders besides insomnia, like OSA, which is obstructive sleep apnea, trouble breathing, circadian disorders, trouble with the timing of sleep. Of course, medications can either cause you to be too sleepy or to have trouble falling asleep. And then other medical disorders, for example, if a child has seizures and they're having seizures at night, that's going to disrupt their sleep. So these are just some of the common kinds of what we call behavioral insomnia. So these are insomnia based on behavior problems or things that you can address, which is what you're going to hear about more from Dr. Corkum in her talk, how we can help people who have behavioral insomnia through behavioral interventions. So sleep onset association disorder is usually in young children. This is children who require their parents to initiate sleep. And you remember that graph I showed you right at the beginning? When they wake up at night, they can't go back to sleep on their own, and they require the parents again to help them fall asleep. Limit setting is just exactly what it sounds like, children who don't have trouble following limits. And so they have trouble with particularly with onset of bedtime, staying in bed and falling asleep. And then sleep timing is more a problem of school age to adolescence. And this is represents children who have a preference to go to sleep late and sleep late in the morning. So their actual sleep might be okay, but they're sleeping at the wrong time. So how common is pediatric insomnia? Probably most people, unfortunately, on the line know that it's highly prevalent because it's just so common in all children, including children with a variety of neurodevelopmental disorders and many children with FASD. So parents of children who are typically developing, about 25% of parents will be concerned that their children don't sleep well. But there's a lot of research that shows in many different disorders where children have comorbid neurodevelopmental disorders that it can be up to 80 to 90%. And one of the problems is that it doesn't just go away. Some people, are told, well, just wait and your child will start sleeping better when they're a teenager, when they're an adult. But unfortunately, children who have insomnia, often can grow up into teenagers and adults that also have trouble sleeping. And what are the prevalent kinds of problems that children with neurodevelopmental disorders have? So I think I've said some of these. I'll just reiterate them because it's important to understand the problems of insomnia. So children who have difficulty following sleep routines, they have irregular patterns, so they're not sleeping and waking at the same time or a similar time each day and night. They're sleepy during the day, obviously, because they're not sleeping well at night. They have trouble with bedtime rules. They get frustrated. There's conflict with parents and siblings at bedtime. They have trouble settling, as I said, night wakings and early morning wakings. And all this leads to not enough sleep or a shortened sleep duration. And what are the consequences of poor sleep? So here's a young boy in this graph. He's obviously very tired because he's at school, and instead of paying attention, he's sleeping. So the consequences are that children who don't sleep well have trouble with learning, their quality of life is affected, there's mental health, so emotional distress, anxiety, depression, and physical health. Even children who don't sleep well are tired. They're obviously not as interested in exercising during the day, and it becomes a vicious cycle because exercise is so important for good sleep. And finally, how does this relationship work? It works both ways. So sleep impacts the presentation of a child with a neurodevelopmental disorder. So a child who maybe has poor communication, let's say just in this example, and then they're not sleeping well, they're not going to be available for their speech language therapy. They're not going to be doing as well with communication. And then on the other side of the coin, the neurodevelopmental disorder might impact the sleep behavior. So for example, a child who isn't able to understand why they have to go to sleep because of their, let's say, their intellectual challenges. So then it's going to be harder to get them to go to sleep at the right time and sleep through the night. Insomnia definitely affects the whole family. It affects the child, it affects the siblings, it affects the family, it affects how the child does at school, it affects how the child does in the community because they may not be able to participate in any activities. It really can affect a child's whole life. And this is just the summary. So I hope that I've stressed that insomnia is any one or all of these: difficulty settling to sleep, frequent waking or early morning waking. Is a very common problem in all children, especially common in children with FASD and other neurodevelopmental disorders. And I think I've also stressed that when a child does not sleep well, there are many negative consequences. So I'm going to hand over part 2 to Dr. Penny Corkum.
Thank you very much, Shelley, for laying the foundation for this presentation. Thanks everyone for joining us. It's really exciting, and just to be here and talk about sleep, as you can imagine, is something that we're all passionate about, and you being here suggests that you're also passionate about it. So it's pretty great to be able to get together virtually to talk about sleep. And thank you, Shelley, for laying down that foundation, really highlighting the prevalence of sleep problems and the impact of sleep problems, particularly for children with neurodevelopmental disorders, but really for any child who has sleep difficulties. There's daytime consequences, child or adult, as Shelley had pointed out. So given the situation, we really need to treat these sleep problems, and there's some good news about this. First of all, is that we actually know by and large what works to help people sleep better. We may not know everything, but we have a pretty good understanding. We have lots of research that really demonstrates how we can treat children and across the lifespan for insomnia. This evidence is more so in children who are typically developing or neurotypical, but there is quite a good size body of research that's quite recent that shows that we can also use some of these same strategies to help children with neurodevelopmental disorders to sleep better. So there's bad news. Whenever there's good news, there's usually bad news. So the bad news is that most children do not receive what we know as evidence-based treatment. Rather, they often are treated with medication. That could be over-the-counter or prescription medication. And this is even more so when a child has a neurodevelopmental disorder. So they're much more likely to be prescribed a medication for sleep difficulties. So why is that? Well, I think there's lots of reasons and lots of barriers to treatment. First of all, I think historically, not so much now, I think people are really tuning into the importance of sleep over the last, say, 5 or so years. But historically, there just really wasn't a lot of awareness or importance given to sleep. And so also we have healthcare providers that are not really trained in the area of sleep. So there's some research that shows that, first of all, it's very inconsistent. So I'm a psychologist, and in some psychology programs, none of the trainees will actually get any training in sleep at all. If you happen to be at a university where there's someone who studies sleep, then you will get a bit more, but it's very inconsistent. It's not part of the core curriculum. And also in medicine, it's a very small amount of time that they'll get training in sleep. So most healthcare providers that don't have a really strong background in sleep. Also, there's not a lot of interventions out there or resources and tools, and this makes it hard for healthcare providers to provide recommendations and strategies around sleep because there's not many places that they can send families and individuals to go for that information. Also, when they are available, and that's not very often, but when they are, it is often delivered in a more traditional format. So face-to-face, say weekly sessions, and this can be very hard on families. So they have to travel to the clinic. They might have to take time off work in order to attend. And so this, I think, results in a situation where not many children are receiving evidence-based treatment for sleep problems. So we really felt that e-health might be a potential solution or to help us bridge this gap between treatment and what the evidence says is best practice. And what we really like about e-health is that it's accessible to many people. It's easy to scale up. So once you've made the intervention, you can scale it up pretty quickly. It can enhance uptake, that's been shown in the research. It can increase efficiency of delivery of the intervention. There's quite a bit of research now showing that it can be quite clinically effective, and that's in other kind of problems. There's not a lot of research in sleep, but the research that's there in sleep, including some of the work that we've done, does show that it can be effective for treating sleep problems. And if you do it well, it can also be very personalized and it can be cost effective. So with that in mind, we built the Better Nights, Better Days program, which is an e-health program. And the first version of this program was funded through the Canadian Institutes of Health Research. And I always like to tell this story. So in the grant, we had that it would take us 6 months to develop the program and then another year or two to evaluate it. So in reality, what happened, it took 10 years to do all of this. So it wasn't nearly as simple as what we thought it might be. We had all the intervention materials already developed. We had tested them in other contexts, so face-to-face intervention trials. And we thought we just had to put it on the internet and everything would be, ready to go. It turned out if you want to make a really good intervention, it does take a lot of work, not only from a programming and content perspective, but delivery perspective. And so the 10 years that we worked on Better Nights, Better Days started with, from scratch, from what we had, from the literature to build it. Then we had to adapt all that for e-health. And then we went out to healthcare providers and we said, this is what we have in mind. This is what we're going to develop. What do you think? And we got lots of feedback from them saying what they could and couldn't support. And so they really felt that it had to be self-guided, that it had to be very responsive to individual needs and tailored for individual needs. It had to be culturally sensitive. And so with that kind of feedback, we finalized the development of Better Nights, Better Days. And then we brought it out to healthcare providers and parents to use and to review and give us feedback. we incorporated the feedback from them and made a better program. And then we conducted a large randomized control trial across Canada. Basically, all that means is that half the people got the intervention right away and half had to wait and get the intervention at the end. And that allows us to compare differences. And the way we have to do it that way because things do change. So we went that control group. And I don't have time to go over all the results, but just to say that it was effective. And not only did it improve children's sleep, but it actually improved parents' tiredness during the day, probably because they weren't up with their children at night. And it also improved children's daytime functioning. So less emotional kind of concerns and less behavioral concerns. So I just wanted to give you a little flavor of what Better Nights, Better Days looks like. So it is designed in responsive design, and that means that it can be accessed on a tablet or a computer or a smartphone, and it's structured around 5 different sessions. And this really follows what we believe is the best approach to treating insomnia in children. So first we have to provide that information, much like what Dr. Weiss just did. Then we want to teach parents how to establish healthy sleep practices for their children, and then help their children fall asleep at bedtime. And interestingly, when you learn how to fall asleep at bedtime, that often applies to when you wake up at night. And so lots of times they finish session 3, and then the session 4, which was supposed to be focused on night awakenings and early morning awakenings, there might not be as much work to do in that session because of the successes with session 3. And then we wrap it up kind of looking back to see what progress has been made, but also looking ahead and see where there might be some barriers. Everything is delivered through, or most things I should say, are delivered through video. Some of it is animated and some of it is real life. There is no coach with this, so it is self-guided. So it empowers parents to kind of use the strategies themselves. But we have like a coach that lives in the program. So this lady here, Ashley, she is both a real person and a cartoon that guides the user through the program. Again, most of it's delivered in video, animated videos, some testimonial videos, and also we do have it quite individualized. You can click the slides there, Shelley. They can fill in different information, and it feeds back kind of progress. There's also some gamification. So there's some developing a bedtime routine, a wake time routine. You track your child's sleep throughout, and you can see that graph for you. And at the end of each session, there's a session plan, so you can print that out so you have access to it. Also, you have to follow it, and it gives you some strategies for implementing those techniques over the next week or 2. And there's also roadblock section. So this is where you'd go if you're stuck or something's not working, to help you problem solve those implementation difficulties. And just to note that the whole program is tailored based on the child's age, the sleep problem that they are presenting with, and as well as being in both English and French. So that's kind of, we had Better Nights, Better Days. We built it, we developed it, we tested it, and everything was working very well. But of course, it was focused on children who were typically developing or neurotypical. And we really felt like that was missing out a large population of children who have sleep difficulties. Like Dr. Weiss said, that sleep difficulties are much more prevalent in children with neurodevelopmental disorders. So we went about to modify Better Nights, Better Days for children with neurodevelopmental disorders, including ADHD, autism spectrum disorder, fetal alcohol spectrum disorder, and cerebral palsy. And this was funded through Kids Brain Health Network. We didn't just kind of make it up. We did a very systematic approach. We reviewed the literature to see what was out there, and we were quite surprised to find a small but growing body of literature really showing that behavioral strategies can be quite effective. In fact, all the previous research had found improvements in the children that participated in those studies. We did a Delphi study, which is just kind of like rounds of feedback with healthcare providers who were focused on children with neurodevelopmental disorders and sleep. So we had that expert view about what needed to go in to make this program appropriate for children with NDD. And then we ran some focus group with healthcare providers, frontline healthcare providers and parents to get some additional information. And then we conducted a usability study. So we had parents use the original Better Nights, Better Days and we asked them what's missing from this. And interestingly, we got lots of good feedback that lots of it was working for them, but there were some specific changes that they would like to see. So I'm not going to go through all of this, but just to say that across all of these studies, really what we found out was a transdiagnostic intervention is possible. And what that means is that, there are some commonalities in terms of intervention across neurotypical and typically developing children and atypically developing children or children with neurodevelopmental disorders, that we can have one intervention, but we can modify it and individualize it for particular situations. So we took all of that information, we met as a team, and the team comprised of kind of across Canada, both clinicians and researchers, and we looked at all that data and we set out to modify Better Nights, Better Days. And so we made a lot more content, we made some revisions, and we did focus it on those 4 different disorders. And that was because that was the focus for our granting agency. So the approach we took is called a modular transdiagnostic approach. So basically we started with the core. So you'll see in the middle there's Better Nights, Better Days, TD for typically developing. And so that's the core. And then we added in layers or layers, I'll call them, for different to kind of reach different or to address different difficulties. So first was a NDD cross-diagnostic modification. So these are maybe challenges that many children with NDD would have. So for example, it might just take longer to implement these strategies. So we gave more time to parents to go through the program. The next layer was symptom-specific modification. So for example, many children with NDDs may have some anxiety at bedtime, or may have, use screens a little more than they should before bedtime. So we added in intervention strategies for those symptoms, if you will. And then the last layer was the diagnostic specific modification. So there are some specific interventions that we need to think about for certain disorders. So for example, children who have attentional difficulties, so they may need some help kind of settling their mind at bedtime. And so we added in these layers so that it would work for children with NDDs, but different NDDs. So in terms of where we are in the evaluation process for Better Nights, Better Days NDD is that we're just finishing up a randomized control trial across Canada, and it's for children ages 4 to 12 or the parents of those children. And we finished our recruitment quite a while ago. So that was February 8th, 2021. And at that point, we had 365 consented participants. So people that wanted to participate in the research study. And we're just now following those families up until the 8-month follow-up period. And we should have all the data collected early in the new year. And so what are the next steps? Well, we're trying to still learn from those parents. So we're conducting interviews about what got in the way of you using the intervention? What helped you use the intervention? We're going to take that information, we're going to modify Better Nights, Better Days NDD again in order to help enhance that implementation. And then starting in February, we're going to run a short, but hopefully large trial with lots of families in the new and improved Better Nights, Better Days NDD to see how the implementation works. And then we have to think about how we're going to sustain it over time. And so that's the Better Nights, Better Days program. And as you'll see, we started with neurotypical children and working with children with sleep problems. And then we modified it for children with NDD. And one of those groups was children with FASD. And so Dr. Hanlon-Dearman will talk a bit about kind of the specifics of that last layer of the modification.
Thanks, Penny. And thanks, Shelley, for setting the stage, and Penny for talking about the behavioral treatment program through Better Nights, Better Days. So my name is Anna Hanlon-Dearman. I'm from Winnipeg, which is Treaty 1 territory. And so I'm delighted to be here. I'm really pleased with the opportunity to speak with everybody here who's attending the webinar in Ontario, and very pleased to be invited by Pascal and Health Nexus to participate in this. I'm also the medical director of our FASD Center, which is a provincial diagnostic center here in Winnipeg. So I see lots of kids who have FASD, and I see lots of kids who have sleep difficulties. And as Shelley already noted, sleep difficulties are very common in kids with all of the neurodevelopmental disorders, and in particular FASD. And we know that from some of the literature already, 85% and probably more of the kids have some level of difficulty with sleep, and that sleep challenge changes over time from when they're very young to when they're older. What we also learned when we looked at this is that their sleep difficulties are complex and ever-changing. They're often shorter sleepers. They may wake more often during the night. They seem to have more parasomnias, and those are the kinds of behaviors like talking in your sleep or walking in your sleep, sometimes tooth grinding, other types of confusional arousals. And importantly, and we weren't too sure about this when we first saw it, but now we realize, we see it quite often, that there's quite a bit of sleep-related anxiety, and it seems to be particularly in the kids with FASD, because I do see kids across all kinds of spectrums. Young children with FASD can look different than older kids with FASD, and certainly different than youth. And when kids are little, in fact, they may become more disorganized or more hyperactive than what you might expect out of somebody who's older, who may simply look tireder. Younger kids can look more aggressive when they're disorganized. Parents may find that their sensory sensitivities or differences may increase, and they're in fact much more sensitive to all of the things that they used to be sensitive to. Now they're really exquisitely sensitive. And they may find that the typical behavioral strategies that they use to help manage their child's behavior just aren't working to the same degree as typically. In FASD, we frequently refer to FASD as really a whole body disorder. And so similarly, when we're talking about sleeplessness in FASD, we find that there may be physical factors from the whole body that are really impacting sleep, and vice versa. Sleeplessness may increase all of the physical symptoms that somebody who has FASD may be experiencing. In addition to the sensory differences and behavioral challenges, all of those become more exquisite, more noticeable, but they may also find that the learning difficulties may really be exacerbated. They may have much more difficulty communicating in general, and also specifically about their sleeplessness, and often may not even put together the fact that the challenges that they're having may be rooted in their sleeplessness. And as Shelley has talked about already, really we have to think about sleep within the family. So the sleep of that individual child or that youth within their family is really impacting everybody. What we've learned from a variety of research studies on FASD, and it's not a huge body of literature, but there is some, is that there's a number of physiologic changes that can result from prenatal exposure to alcohol that themselves can affect sleep architecture. It can affect what we call the circadian physiology, or the day-to-day rhythms of sleep and wakefulness. And it can even affect respiratory control, because all of those things are controlled by brain functioning. And we know that prenatal alcohol has a global brain effect. The effect of prenatal alcohol exposure, it really has lasting sequelae in both health and daytime function, but so does the effect of prolonged sleep difficulties. Not to mention when you have parents who are chronically sleep deprived, it really affects the whole dynamic within the family. And so what we find is that all of those interpersonal relationships within the family really get restructured by this perception, but I mean, it's a real perception of what's a difficult sleeper. And I can't tell you how many families I've seen who have talked about their child having difficulties from sleep virtually since birth. So this has been a struggle that families have dealt with all the way along. It's important when we think about treatment approaches for individuals who have FASD and sleep that we really have to think extremely holistically. So we know that any stressors in that prenatal environment above and beyond the prenatal alcohol exposure can further impact the organization of that little person who's going to be born and further impact the risk of sleep disruption. We know that things like prenatal stress, malnutrition can impact circadian rhythm or that day-to-day sleep-wake rhythm and result in poor sleep quality. And we also have, there's a really good body of literature that really talks about how maternal mood, so depression, anxiety in a mom, can be further impacted by alcohol. It can be further impacted by sleep disruption prenatally, and it can also predict poor sleep in toddlers. Many of the kids that I see, 60 to 70% of the kids that I see are in care. Now, this may vary in different clinics and across Canada, but kids in care have a predisposition to having trouble with sleep, probably for a number of environmental reasons that have to do with attachment and instability. But we also know that kids who have FASD are overrepresented in kids in care. And so when you take the disrupted attachment, any social disruption that a child may have experienced, and you add to that prenatal alcohol exposure, and then you have some environmental insecurity for kids, and many of the kids I experience have lots of disruption right up until teenageness. It can really be quite challenging, and it can be really frustrating and challenging for well-meaning parents to try and help manage the kids' sleep hygiene. And in fact, there will be, and I will talk a little bit about sleep hygiene because that's part of it, but as any parent who's looked after a child with FASD or a youth with FASD knows, it's not just sleep hygiene. It really has to be encouched in a total sleep program. The goal in managing sleep for anybody, of course, is to reduce the burden of care, and this is challenging. We may need to address multiple areas at once. There's lots of give and take that we can have when I talk with families about, priority setting and what's the most important, but also the most doable goal to do. And it's really important to recognize that kids who have a history of trauma, kids who are newly adopted, kids who have chronic medical problems, we may need to take special care. And often families are referred to sort of many of the books that are out there on sleep that you can get from Chapters or any of the bookstores. But we have to recognize that special care needs to be taken when there are special circumstances. And while some of the principles may work, the implementation of the principles has to be a little bit different. So the general considerations when I'm managing a child is really to ensure that there is a team approach. And while, many of the families I talk to often don't feel like there's a team, they'll tell me, especially since COVID, it's either me and my doc, or maybe I don't even have a doc, or maybe I just have a nurse practitioner or a therapist. It's really important to build a team around you as a family, and for your child to really sort of approach things from different ways, because there are different roles that different members of the team can participate in here. It's really, really important to treat early so that we prevent some of the secondary consequences. And it's really important to have a good developmental evaluation so you know kind of what level your child is working from, what their strengths are, and what their areas of challenge. We can use those strengths in working with them to develop a really good sleep plan that's helpful. It's important to manage other complex symptoms like mental health and behavior. And it's really important to talk about the environment and sleep hygiene. And I am going to talk a little bit about melatonin and other medications, but only very briefly, because as Penny has talked about, really the primary approach can and should be a behavioral approach, and then we sort of add in where we need to add in. So sleep health, again, I think I'm talking about some of the similar things, but if you think about what are some of the basic principles, some of those sleep hygiene, and you'll see I've put it right at the top there. What are some of the behaviors we need to stabilize and manage in the family? What are those day-to-day rhythms that we can help with? What are some of the sensory considerations that we need to be mindful of and support? And then what may be some of the areas that we need to target for medication and managing some of those complex symptoms. I don't think I'll spend too much time here. This slide is really to reinforce to everybody that prenatal alcohol exposure causes neurological disruption in a child, but sleep is also neurologically mediated. So the two of those have this sort of interrelationship where a lot of what you're trying to do is manage a somewhat dysregulated neurological system that is either over or under aroused, and that really throws off the balance of sleep and wakefulness. So how can we work with that in the best way possible to really help kids get a good night's sleep? A good night's sleep, as a wise woman, Mary Kurchinka, said one time, begins first thing in the morning. So we have circadian approaches that we really don't just think about implementing the sleep hygiene approaches later in the day, but really start at the beginning of the day. We talk about routines. We talk about not just sleep and wake routines, but mealtime routines, the daily rhythms, and how do we really integrate that? We get as detailed as, what does breakfast look like, and what are the deep pressure points and the heavy work sensory pieces that I'll talk about in a second, and where can we work with the meal times to really work with a child. Sleep hygiene, again, I won't spend a lot of time, but we'll be happy to answer questions on, as will any of us. A sleep bedtime routine is incredibly important, as along with all of the things that help us calm, downregulate our wakeful systems and support our sleeping systems, like having a cool bedroom and having for sure a dark bedroom, and really having a good talk about media, screen time, all of those kinds of things, having a calm, quiet, well-regulated environment. Shelley already talked about our sleep-wake rhythms. Our hormones also have sleep-wake rhythms. This slide particularly shows melatonin, how it's sort of released at night when it's dark, and it's suppressed during the day when it's light time. So it's really important to have a good daylight and darkness balance. Here in Winnipeg, we get dark now at 4:30 in the afternoon, and it's pitch black already for us. So, really important to sort of think about that, but then in the morning to really have those blinds open and keep light going, and think about when we get physical activity. I know it's been challenging with COVID to get kids out and doing some of those daily physical activities that they need to do, but it's a really important part of their sleep. And when the timing of that is also really important. These are just some of the sensory strategies that we can consider in the environment. I've kind of clustered them the way occupational therapists will think about them in terms of visual and auditory and tactile things, but every child, every youth is different. I find that adolescents, we often don't think about these things the way we may as preschoolers. We tend to think about all of those sensory strategies. But the same thing goes for older children and adolescents. They may be different. They may have to express their sensory needs in a little bit different way. And we may need to think about strategies that are different than we do for when kids are, 3 or 4 or 5 or 6. But it's really important to recognize that these preferences are wired in, they are what they are, and there are ways that we can help somebody work with them to help calm them a little bit. And sleep support for parents, I think all of us have tried to reinforce that. And the baby blues cartoon that says, when you're grumpy when you don't get enough sleep, and the mom who says coffee first, talk later. Hopefully some of you can recognize that a little bit. Some of the things that I've noticed particularly can be sometimes parental use of screen time, or other teenagers in the house, other kids or adults in the house, thinking about parents' sleep patterns that may or may not be in sync with the sleep patterns that they expect out of their kids, and what are parents using to cope with not just sleep, but behavior and what may be functional and dysfunctional. So sometimes we really need to do quite a bit of talking about a variety of things that are affecting household functioning. So very briefly, I'm only going to spend a couple of slides here. If you'll recall, Dr. Weiss talked about difficulties with sleep, kind of thinking about them as difficulties falling asleep, difficulties staying asleep, and difficulties regulating sleep a little bit. So when I put a medication approach here, I'm not trying to say that behavior isn't the first approach, because actually for all of these, behavior is the first approach. But sometimes you do get to a point where you do have to think about it. And so I think it's important when we're at that point to really think about what are we targeting when we're choosing a medication. And this is just a perhaps overly simplistic kind of view of how to think about that. So difficulty falling asleep may have a circadian rhythm component to it. It may have a component of simply being overstimulated or over-aroused, or it may have a component, for example, of being anxious and unable to fall asleep. And you can see that if you follow the track down, the medications that we may choose are actually quite different if we're choosing medication for any of those. And you know, I find that something like melatonin, for example, and I suspect Shelley may agree with me here, is that it's quite overused. And so what happens is it gets overused because maybe it's being used where the actual issue may be hyperactivity and over-arousal. And then people may find that it isn't working as well because really what they need is that overactivity managed first, and then deciding whether you need melatonin as an add-on. And similarly for anxiety. So I think it's really important to be very clear in your head, what is the issue, and work through some behavioral components and try and figure out what to target. Similarly with the next slide, if we're talking about difficulty staying asleep, here melatonin actually isn't super good at that. There may be a role for it, but it's not really a first line. So again, we're thinking, is there an anxiety component that's at work here? Is it a self-regulation component? Is it a behavior? Is it either behavioral stabilization, or for younger kids, and I haven't put that on here, really, is it around limit setting and learning how to self-soothe? Or could there even be a restless leg component? Again, depending on what the issue is, we may actually go in different pathways in terms of treating this. Similarly, in the final slide, early morning awakenings, and I see this sometimes, but usually these aren't the bigger issue for many of the kids I see. They're often in combination with some of the other ones that we've talked about. But again, kids who are anxious may wake early. Kids who simply have a decreased sleep need may be being put to bed too early and simply waking too early. And you can see that that one doesn't have a medication component. It really is about managing that behaviorally. And again, circadian rhythm, we may be able to do some work with melatonin there. So these last three slides are really to help you understand that there are really different directions that we could take. I really want to support all of you in the audience who are really thinking about early FASD assessment and diagnosis, that's really important in understanding the approach here. Really understanding what those brain domains are as part of the assessment, so you can really work with a child's strength and work with what their needs are. Applying the principles of sleep hygiene in a comprehensive sleep management plan, use medications when appropriate, and really think about the sensory needs of an individual with FASD, because they're often overlooked, especially as kids get older. And my final slide, in the final slide, it's really to think about disorders of mood and disorders of arousal, attachment difficulties, and most importantly, appropriate caregiver support. So I think with that, I'm really going to close. I know we've all gone through these very quickly, and I'd really like to open up, along with my colleagues, Dr. Corkum and Dr. Weiss, to any questions that there may be. And thanks, Pascal.
Well, thanks to you, and we're really excited to hear about the latest development in sleep research, as this is an area that many are not aware how important it is to support individuals and their families. I saw a few questions in the chat. The first one was already resolved, to clarify the prevalence of insomnia in neurodivergent kids. And Dr. Penny Corcoran answered depends on the neurodevelopmental disability, but up to 80 to 85% versus 25 and 30% in neurotypical children. And concerning the frequency, it's astounding we don't talk about it so much more. Another question in the chat was, are there any references for the presentation? I would be interested in articles for prevalence. So that was answered. I had previously heard that children with FASD have a fluctuation of natural melatonin throughout the night, which impacts their sleep. True or false?
Yeah, so there's not a lot of research on this, but there was one study on this, and that suggested that there was some variation in that. I want to kind of reframe the answer to that in terms of helping people understand what's required to do that kind of research. To do that kind of research, what we have to do, and I do this in some of my other presentations, is you have to actually have a child come into hospital for an overnight sleep study. So picturing a child with FASD, and when you come in for an overnight sleep study, all of the stickies that are on your head to have an overnight EEG and on the rest of your body, then you have to have an intravenous lock put in your hand, and you have to have blood drawn usually about every single hour so that they can test the melatonin and get a nice melatonin curve to do that. So any of you with kids will recognize that that's probably not the ideal way of having to do this. So there's very limited research. What there is suggests there probably is some difference there, but that's as close as I can get.
Thank you so much. And we can see how inconvenient that would be with a kid to figure that out.
Yeah.
Someone else asked, I'm in the process of adopting a 12-year-old boy just diagnosed before placed with us with FASD. Where is the best place to start to get help in understanding more on how we can help him? He has a host of other diagnoses, and he doesn't sleep. He doesn't stay asleep and wakes up early. So, where would you start with that family?
I think what I would suggest starting with is going, if you can, to where the child was diagnosed, because the process of diagnosis should have a pretty comprehensive neuropsych profile done, and that will give you a picture of where his cognitive functioning is, what his language abilities are, any areas that need support. That should all be in that kind of an assessment. So if you can access that, that would be super helpful for him. And then you can kind of begin from there to sort of understand what are the areas that he really needs support with.
So it's linked to another question in the chat. So is there a program we are able to sign up on how do we get the help we need? So are you aware of any clinics or programs other than Better Nights, Better Sleep, Better Nights, Better Days?
Yeah, I think I don't know if that question was anything like outside of Better Nights, Better Days. I mean, as I had mentioned and Dr. Weiss had mentioned, there's really very few resources and programs for children with sleep problems, particularly children with neurodevelopmental disorders, and maybe even more so children with FASD. It becomes very complicated, like and I was talking about kind of doing the research in this population, but also doing intervention research can be hard too, just because of some of the guardianship and changing of parents. So we had quite a bit of difficulty recruiting families into Better Nights, Better Days, NDD, with children with FASD. And I don't think that reflects that there's not a need for it, just that it can be quite challenging. And so I don't know of a specific sleep program that's specifically for children with FASD. I would say that in February, we will have the Better Nights, Better Days NDD new and improved version out for implementation study. So that would definitely be a good place to start, and it could help provide you with some information, some tips and strategies. And it does provide quite a bit of information about like sleep and FASD specifically, and what you might need to do to help your child sleep better.
Yep.
Can I just add two things? If you want to look at our website, you can follow when we're going to be actually recruiting people for the implementation study. And the second thing I want to add is that, even though we definitely know that healthcare professionals don't have especially as a sleep person, they don't get enough training in sleep, you still should go to your primary care physician If it's a family physician, they would refer you to a pediatrician. If your pediatrician can't help you with the problem, they'll refer you to a developmental pediatrician. There might be a psychologist in your area who has some expertise. So we don't want to leave you with the impression, that there's no one out there who can help with these sleep issues, because definitely there are people that can help you.
And I guess just to add to that, the Canadian Sleep Society, and you could just Google Canadian Sleep Society, they do have a list of providers for treating sleep problems across Canada. So you could also look at that list, might help give you a little direction.
And I'd add to that also, occupational therapists can be very good at managing many of the behaviors, like the sensory things and the sleep routines and things like that. So if you have one, that would be a great question for them. And if you don't, it might be worth a consultation.
I see there's a lot of people who are interested in your program, and someone said, how can I sign up my 4-year-old to Better Nights, Better Days? So there you go. Yeah,
that's always good to see. So right now we're doing a Better Nights, Better Days during COVID study for the next month and a half until January. And so that's not specific for children with NDDs. You're welcome to participate in it, but it's not going to be as targeted and as tailored. And so you'll have to, the next time that we're going to have Better Nights, Better Days NDD available will be in February. And you would just go to our website. So keep your eye on that. Soon we'll put up a notice and you can just sign up and we'll let you know when it's open. And then basically you just have to go through the website, you answer some questions, and then you're enrolled in the study. The nice thing about an implementation study versus kind of our typical randomized control trials is that there's no like randomizing to treatment versus wait list. You just get the treatment. So that's a nice part of an implementation study. There's no chance of not getting the treatment. So I'm going to actually talk to someone about putting up a little web form on our website so that you could sign up now, and that way we can keep you posted when it's up and running. Perfect.
And if you can post it in the chat, that would be lovely too.
I'll do that.
And I saw someone mention clinics like Sleep on the Bay as an offshoot from Youtdale in Toronto. Or I know the sleep clinic in Ottawa as well. So again, we won't spend too much time on particular service providers, but please check in with your general practitioner for referral to appropriate services in your local area.
Yeah, and I'm just going to jump in there because Canada's very interesting in terms of sleep services. So I'm in Nova Scotia, and in all of Atlantic Canada, we have no pediatric sleep service, period. None. Zero. And so if a child needed a polysomnography to see if they have sleep apnea, say, for example, they'd actually have to travel to Toronto or Montreal. And I had a family who had to do that. So it was a child with autism spectrum disorder, first time on a plane, first time without both parents. You can imagine it didn't work out, right? So it's very unfortunate, the disparities around sleep health across Canada. So if you're in Toronto, you might have a little more luck. In Halifax or other Atlantic provinces, you're not going to have much luck. The only options really like private clinics, and not sleep clinics, but private people. Yeah.
It's not too strong to say that sleep is a health equity issue in some.
Yes, definitely. Yeah, no, good point.
Speaking about interventions, you mentioned, Anna, that the implementation of sleep strategies may look different for people. Could you speak more into that? Because that was really interesting to me.
Yeah, the menu of sleep strategies that we think about behaviorally is pretty common. We talk about things like sleep hygiene, etc. But for every child, different parts of that are more important, or for every individual, because it's really the same for adults. So, I see also some comments in the questions about what a nightly routine would look like, and whether it involves a heavy work or a weighted blanket and all those types of things. It really depends on the child. And that's where, if you understand the child's sensory preferences, for example, some kids will love a weighted blanket and it works really well for them. Other kids hate it, they kick all of their covers off. Some kids, if you understand how many hours of sleep they need per night, you can figure out when they should go to bed and when they should wake up, but you really have to do some figuring with that. If some children are calmed down in the evening by having a bath before bed, other children are stimulated by having a bath before bed. So it really is important to do some really clear thinking about your individual child or youth, and thinking about things like what calms them in those couple of hours before bed and helps them down regulate their system. And if they're kids that also need to have some outlet for all of their energy, when can I do that during the day that makes more sense, which is probably going to be earlier during the day. So you really have to think about the day as a whole package and that child's individual preferences within that package. So there's no one size fits all.
I see a question that may be fit for Dr. Penny Corkum about the buy-in for kids to follow a sleep routine or sleep hygiene.
Yeah, I saw that question. It's an interesting one. It's always hard when they get a little older and have more say into the whole situation. I think, like everything, it's a little easier if you start younger and you get that buy-in early. But I would say, I have most luck with adolescents or pre-adolescents, getting them really engaged in the process, like almost making it an experiment that they're a part of, and I think where we might go wrong sometimes is kind of forcing something, because you're going to get a lot of, resistance to that. But, let's try this out. And if you can do it as a family, I think it's really exciting. So like, I was just thinking what Anna just said about, children need to be calm. Everybody needs to be calm. You need to be calm and focused to go to sleep. Electronics are just bad for everybody before you go to sleep. Like, this is a universal. So what about if the whole family parks their phones in the kitchen before they go to bed? What if we make that like a family, and then let's check in and see how we did with that? How hard was it? But you can't just tell your kid to do it, but yet you lay in bed looking at your phone. Like, that's not going to work so well. So I think making them an active participant as much as you can. And I appreciate that sometimes that's not as simple as I may make it sound, but any way that they can be involved, or using reinforcement like rewards, like, making a big deal for them to follow those routines, because it is hard. It's like learning a new behavior. And so, I think we have to appreciate how much effort it does take, and make sure that we're rewarding that effort.
I have a question now for Dr. Weiss. Could you speak more into the importance of sleep for development of children? You see a lot of them, and how are children developing if they get good sleep versus the ones who don't?
Yeah, that's a good question. So there's no research that shows like a child who is chronically missing a little bit of sleep is going to have any difference in their development trajectory, that they're not going to reach their potential. It's more that, there's going to be more emotional problems, more behavioral problems, more distractibility. But in the ultimate end, a child who's typically developing, we don't have any research to say that if they have insomnia, they're not going to reach whatever potential they would have reached if they were good sleepers.
As a follow-up to that one, our last speakers to present at a webinar, Dr. Laurie Cabral and Maud Champagne, spoke about the importance of sleep as a way to regulate child-to-parent aggression in the home, which seems to be strange, but is linked to the best results they've seen when doing therapy and intervention for safety. So could you speak more about the importance of sleep for adolescent and even adults with a disability?
I'd love to just jump in there, because I think that's a really fascinating point. I mean, one of the first things I learned about from sleep research many, many years ago was that children who have sleep difficulties are at increased risk for child abuse. And so, I always, that stuck with me for many years, trying to figure out, well, why would that be? And I think when we think of the impact of poor sleep on children, so they're going to be irritable, they're going to not be able to regulate their emotions as well, they're not going to be able to have behavioral regulation. Sleepy children have sleepy parents, right? Because they're keeping the parents up as well. And so the parent's going to have the same problem. So then you have a situation where you have, everybody in the family, or at least the parent and this child, are both going to be dysregulated emotionally and behaviorally. So you can imagine how that could set the stage for some more harsh discipline and some more difficulty. So it doesn't surprise me that sleep came up as a factor that protects people from kind of those negative interactions. But that's really interesting. Yeah.
Thank you. And as a final question, I know someone that I worked with who said that he would drink a glass of whiskey every night to fall asleep. Could you speak more into adults who use substance use to help regulate insomnia, or alleviate the impact of anxiety?
Yeah, I won't talk about your friend specifically, but we know that alcohol helps people. Alcohol helps people fall asleep. It does not keep them asleep. So the first thing that we talk about to adults who have insomnia is good sleep practices, including not using alcohol.
Thank you so much. So please check out the Better Nights, Better Days website. We are really happy and excited for that research to unfold, and hopefully we'll be able to share the results later on. Stress the importance of sleep with your physicians. It may be something useful for yourself, your family, and your peers as well. And if you're a service provider, please check out if there's any sleep clinic that you can navigate your clients to in order to improve their quality of life. On that note, thank you very much and have a good night. Sleep well.